Hello everyone, once again welcome to my YouTube channel. In this video we will discuss about the uveitis. So at first we should know that the uveitis is the inflammation of middle layer of the eye. So the standardization of uveitis nomenclature working group guidance on uveitis terminology endorsed by the International Uveitis Study Group IUSG categorize uveitis anatomically. So this is the classification of uveitis based on the International Uveitis Study Group. So the first is anterior. The anterior chamber is primary site of inflammation. Intermediate primarily vitreous inflammation includes pars planitis, posterior retina or choroid, and the panuveitis. All uveal structures are involved. An IUSC clinical classification based on etiology is also in use. Infectious, so uveitis can be infectious also, that is the bacterial, viral, fungal and parasitic. The non-infectious uveitis with and without a known systemic association. So if we have any systemic disease, so it can also cause uveitis. Now we will discuss about the mass quadrate, neoplastic and non-neoplastic. The Sun Working Group guidance includes the following descriptions relating to the timing of inflammatory activity: onset sudden or insidious, duration limited 3 months or less or persistent, clinical course acute of sudden onset and limited duration, recurrent repeated episodes separated by untreated inactive periods, or chronic persistent duration with relapse less than 3 months after discontinuation of treatment. Remission is defined as inactivity, no visible cells for 3 months or later. So at first we will discuss about the anterior uveitis. Introduction. The anterior uveitis is inflammation involving the anterior uveal tract, the iris and the anterior part, that is called pars pellicata, of the ciliary body, and is the most common form of uveitis. Iritis refers to inflammation primarily involving the iris, and iridocyclitis to involvement of both the iris and anterior ciliary body. The practice these are interchangeable as they cannot distinguished clinically. Acute anterior uveitis is the most common presentation, of which HLA-B27 related and idiopathic form make up the largest proportion. Etiology in these cases is uncertain but may genetically predisposed individuals. AAU can be a feature of wide variety of ocular conditions such as trauma, including surgery, lens related inflammation, and herpes simplex infection, that is a virus, or can be secondary to inflammation elsewhere in the eye, such as bacterial keratitis and scleritis, can also cause anterior uveitis. AAU can also be the presenting clinical scenario without accompanying accompanying intermediate or posterior uveitis in a range of systemic conditions including chronic inflammatory disorders such as sarcoidosis. Anterior chronic anterior uveitis is less common than AAU. It is more commonly bilateral, and associated systemic disease is more likely. Granulomatous inflammatory signs seen below are often present. Surveys of systemic association of anterior uveitis vary in their finding. List important possibilities but is not exhaustive. The prognosis is usually good in most idiopathic and HLA-B27 related AAU provided management to adequate Outcomes are more variable in CAU and in cases where there is an underlying ocular systemic disorder. There are some symptoms of the anterior uveitis, that is, the visual acuity is variably impaired depending on the severity of inflammation and the presence of complication. It is the frequently only mildly reduced in AAU. Ciliary injection, perilimbal injection, ciliary flush, or just injection is circumcorneal conjunctival hyperemia with a violaceous purplish due to involvement of deeper blood vessels and is typically seen in anterior uveitis of acute onset. Ciliary injection is characteristically absent in some forms of CAU and occasionally AAU. Now we will discuss the meiosis due to pupillary sphincter spasm predisposes to the formation of posterior synechia. So there are these diagrams are showing the ciliary injection, meiosis, anterior chamber cells in mild anterior uveitis and hypopyon. So this is the grading that if any patient have uveitis, then we will get a sign of cells and flares in the anterior chamber. So this is the grading of cells. So if grade 0, then we will get the cells less than 1, and if 0.5 plus, that is 1 to 5 cells in the anterior chamber, 1 plus yani 6 to 15 cells in the field, 2 plus 16 to 25, 3 plus 26 to 50, and plus 4 50 or greater than 50, 50 or less than 50. So this is the table showing the grading of cells and uveitis. So this was all about the anterior uveitis. Thanks for watching my video.